Welcome to Med1 page. My name is Benjamin, and today I'm going to be talking about the cancerous tumors of the breast, that is breast cancer. So I made a video about the benign tumors, or the ones that do not become cancer. You can watch that out. So on local breast cancer, this is a very important topic because it covers up to 20 to 30% of all cancers in women, and it is the leading cause of death, the leading cancerous cause of death among women worldwide. And when we look at some numbers, the WHO reported that almost 2.3 million cases were reported annually, that is in 2022, and 685,000 deaths per year were due to breast cancer. And there is a lifetime risk of 1 in 8 women. So in 1 in 8 women, you see there's a risk they could develop breast cancer. Then it's also worth it to note that breast cancer not only occurs in women, can also occur in men, and that is 1%. And when it occurs in men, it is very aggressive because of their reduced actually tissue. So invasion or metastasis is very, very high. So looking at the anatomy and the physiology of the breast, this is very important to understand because it gives you a picture of how breast cancer is going to start and how it's going to spread. So when we begin with the anatomy, breast cancer, the anatomy of the breast in relation to breast cancer. So it's worth it to note the breast has around 15 to 20 lobes, and these ones enter empty their content or their secretions into the lactiferous ducts, which then deposit them through the nipple outside the body. Then we have the terminoductalobular unit, which is made up of the ducts and the lobules. The lobules produce the secretions. The ducts are the ones that transport them or propel them out of the breast, and these ones form the place where most cancers are going to come from. Then the stroma is the fibrous tissue in which these terminoductalobular units sit. It's just the connective tissue that make the bulk of your breast. Then the blood supplies from the internal thoracic, the radiotherapy, and the intercostal arteries, and it's supplied by the 4th and 6th intercostal nerves. So the lymphatic drainage is one of the most important thing when it comes to breast cancer, and we group them in 2 levels, that is level 1, level 2, and level 3. And why we came up with these levels, or why they came up with these levels, is because the lymphatic drainage from level 1 pours into level 2, and the lymphatic drainage from level 2 pours into level 3. So you see that if a lymph node at level 2 is affected, you will have to dissect both level 2 and level 1 lymph nodes. But if the lymph node in level 1 is affected, you may need to remove the level 1 lymph node. And if level 3, most times there's not going to be dissection, or because of the consequences, which will be a lot of lymphedema, and it's one of the complications of mastectomy with lymphatic dissection, and we shall look at that later. So the other lymph nodes, apart from the axillary lymph nodes, which take 75%, around 15% is taken by the internal mammary, and the internal mammary are going to point to the mediastinal lymph nodes, and mediastinal lymph nodes will take it to thoracic duct. Then we have the supraclavicular lymph nodes, and sometimes we have the subdiaphragmatic or the abdominal lymph nodes, and also the abdominal lymphatic system being involved, and this explains why we have sometimes metastasis to the liver. So the axillary status is a key prognostic factor, whereby the amount, the nature of the way how lymph nodes are affected in the axilla, that's the armpit, is going to tell us how aggressive or how far or the malignancy of the tumor we have. So the hormonal control, estrogen is important for proliferation of the ducts, but then progesterone is important for the growth of those the labialo-alveolar growth. So during the luteal phase, that is the phase after ovulation, we're going to have engorgement and tenderness, and post-menses, things have to go back to normal, where we have the epithelial turnover, whereby the previous cells have to be shed off or die, and then we have new cells being made. And during this process, when the cells are turning over, it is a weak point. It is a point of weakness where mutation can occur. Cells may actually wipe up, proliferate, or grow very many and cause cancer. They could develop atypia, where some errors occur in their genetic material also predisposing to cancer. Then we have the estrogen receptor, and progesterone receptor positivity, and this one is important because it guides hormonal therapy. For example, that's like tamoxifen. So when you look at the risk factors, you have the modifiable and non-modifiable. The non-modifiable risk factors increase age, and that is women around 40 to 50 years are mostly in the window where people are diagnosed with breast cancer, being female, a family history of having a BRCA1 or BRCA2, as well as the TP53 and the P10 mutation, early menarche, late menopause. And when you look at early menarche and late menopause, this means this person has been exposed to estrogen for a very longer time compared to other counterparts. So it is going to be, and remember, the most common types of breast cancer are hormonal driven. So if you're exposed to estrogen for a longer time, there's a chance that you will develop that. Then we have dense breasts. Then we have the modifiable risk factors, that is nulliparity, whereby someone takes long to have kids, or late first pregnancy, where it takes long to actually have your first baby. This is going to leave a very long period of exposure to estrogen, because during pregnancy, estrogen is kind of low and progesterone predominates. So when this person is exposed to estrogen for a longer time, they stand a higher risk. OCP or hormone replacement therapy. OCP is the oral contraceptive pills or the hormone replacement therapy. And this one's also is very easy. The pills contain estrogen. You expose this patient to estrogen, the estrogen will drive proliferation in the breast. So then we have obesity. Obesity, in obese people, there is peripheral aromatization of testosterone to estrogen. So there is increased estrogen production from the fat cells, and this estrogen is going to work on the receptors, and the receptors are going to stimulate hyperproliferation, which eventually will lead to cancer. Then we have alcohol, and we have radiation. Then we have genetic. We have the genetic factors, that is the BRCA1, which include the triple negative, which gives us the triple negative breast cancer, and this is the most aggressive form of breast cancer. We have the BRCA2, which gives us the estrogen receptor positive and breast cancer. This one relatively has a better prognosis. Then you have the TP53 mutations, which give us the Rule-for-Omani syndrome. And this syndrome, of course, comes with other manifestations other than breast cancer alone. Then the Cowden syndrome, which is a mutation in the P10, will also come with other syndromes like other hematomas and development of colon cancer and many other things. So when you look at the clinical features of the signs of breast cancer, we have a painless lump, and this is going to cause asymmetry, or these changes, or the breasts are not going to be the same size because of that painless lump. We're going to have nipple inversion or a discharge, which can be bloody. We can have skin changes. That is the dimpling. The dimpling is going to be caused by infiltration of tumors into the ligament of Cooper's ligament. And this is the ligament that suspends the breast, make sure the breast is held up. So if it is invaded by cancer, it is going to be pulled backwards because of fibrosis. And when it's pulled backwards, it's going to cause a dimple in the skin of the breast. Then we have the orange, which basically means orange skin-like appearance of the breast. So this is going to occur when the lymphatics are invaded by the cancer, and then when the cancer invades the lymphatics are going to be blocked. That is the lymphatics draining the skin. So when they are blocked, we have a kind of edema or fluid collecting within the skin, and that is will appear like an orange skin peeling. Then we have ulceration, which is common in inflammatory breast cancer. Then regional, we can have the axillary, supraclavicular, and internal mammary nodes always affected. This time we can have things like bone pain, dyspnea, jaundice, and so bone pain is going to occur when we have the metastasis to the bones, dyspnea to the lungs. When we have jaundice, it means the liver is affected, and neurological deficits will occur when the brain is affected. So the tumor's biology and spread is that we have cellular mechanisms that increase proliferation, angiogenesis, and apoptosis evasion, which means the cells do not die after they are formed. That is apoptosis evasion. Then receptors are overexpressed. The tumor tends to overexpress estrogen and progesterone receptors. Remember, these hormones are everywhere in the body, so if you're ever expressing these receptors, the hormones are going to go there, and then we have aggressive proliferation. Then we have a human epidermal receptor 2, human epidermal growth factor receptor 2, overexpression also. When it is overexpressed, we're going to have aggressive proliferation, and this one also gives a very deadly kind of cancer. Then spread, it is coming from the lymphatics to the internal mammary nodes and the axillary nodes. Then after that, it may breach into the hematogenous system, and when it enters the blood, it will spread to the bone, the lung, the liver, and the brain. So when you look at the pathogenesis on a molecular basis, the sequence of events that we have a normal cell, then it goes, we have to have hyperplasia. Then after hyperplasia, we have atypical hyperplasia, which is hyperplasia that is abnormal. The increase in number of cells is abnormal. Then we have a carcinoma in situ, which is the one that has not yet broken through the basement membrane. And I will explain that. Then we have the invasive carcinoma, which has actually now broken through the basement membrane. So when we look at the molecular subtypes, we have what we call the luminal A, the luminal B, the HER2 enriched, the triple negative breast cancers. And the luminal A is basically, we're having a ductal carcinoma. It's originating from the ducts. And ductal carcinoma is actually the most common type of carcinoma. So remember, we say cancer comes from the ductal lobular unit. So we have the duct and the lobules. So the ducts have the most places where we have most of the cancer. And these ducts are lined by epithelium. So this epithelium is always going to be responsive to estrogen. So when we have estrogen working on the cells in this epithelium, they are going to grow very fast, and we shall have atypical hyperplasia, which will eventually lead to the carcinoma in situ. So when this breaks through, we can again go to having the cancer spreading. So luminal A has estrogen and progesterone receptors negative, and the HER2, the human epidermal growth factor receptor 2, is negative. And because this is negative, we're going to have a slow growth, and this cancer has the best prognosis. Because when you look at the way you're going to manage this, hormonal therapy will almost be very good here, because the estrogen and progesterone will block those. You antagonize those two hormones, you could actually have the tumors regressing. Then you have the luminal B type now. The luminal B type has estrogen and progesterone receptors positive. So they are ever expressed, but on top of that, the human epidermal receptor growth factor is. And this is going to also increase proliferation. But the thing is, there's moderate prognosis because of the HER2 being positive increases on the proliferation of this. Then we have the HER2 enriched, which has negative estrogen and progesterone receptor. And this is bad, because it means it's being driven, it's non-hormonal, it's not so driven by the hormones. And the HER2 is going to be positive, and most of the time it's responsive to trastuzumab, which is a monoclonal antibody kind of treatment that targets the HER2 receptors. Then we have the triple negative breast cancer, and this is the worst form of breast cancer. It is associated with the BRCA1 gene, which is also, after the BRCA1 gene is also seen to be the one involved in men's breast cancer. So it is a high-grade cancer, it has a poor prognosis, and it is commonest in the BRCA1 people. So we have the invasion and metastasis of breast cancer. So what happens is that during breast cancer or development of breast cancer, we have loss of ecadherin. Now, ecadherin is a kind of molecule that helps to hold the basement membrane of the cell of the cells. So what happens is that the tumor cells, or the cells that have been affected by cancer, are going to lose their ecadherin. When they lose ecadherin, the thing that holds them together, causes the adhesion of them together, then they're free to roam. So they start to spread. So when they start to spread, they're going to produce the matrix metalloproteinases, the MMPs. And these are going to be the ones, they act like scissors. They're going to go to the basement membrane and cut it through. So when they cut through the basement membrane, we are going to breach it, and then we have spread of these metastases into the lymphovascular space, that is to the bloodstream and to the lymph nodes. And they spread via the axillary lymph nodes, and they spread via blood to enter the bone, the lungs, the liver, and the brain. And that is how we have breast cancer metastasizing. So we have the classification of breast cancer, and you can do that by location, by invasiveness, and then we have the WHO histological types. So when you look at by location, you have the ductal cancer, or the ductal carcinoma, and then we have the lobular carcinoma. And the ductal carcinoma is the most common, and most of the times has a better prognosis than the lobular carcinoma. So when you look at the invasiveness, we have the non-invasive, that is the ductal carcinoma in situ and the lobular carcinoma in situ. So what happens is that the ductal carcinoma in situ is that we have atypical cells or malignant cells within the ducts of the breast, but they have not left the ducts. The ducts are always lined by this kind of basement membrane. So the cancer is still held behind this gate. So we call that the ductal carcinoma in situ. And then the lobular carcinoma in situ is the same thing. The cancer is held within the lobules and has not yet left. And it becomes invasive. The invasive ductal carcinoma, that is in 75% of cases, is going to be invasive ductal carcinoma. That is when it breaches that basement membrane and leaves and now starts spreading to the rest of the breast. And then we have the invasive lobular carcinoma, and that is in approximately 10% of the cases. In other cases, we have other rare causes. Then when we look at the WHO histological types, we have a medullary breast cancer, where we have syncytial sheets and lymphoplasmacytic infiltrates, and it is mostly linked to the BRCA1 gene, and it also sometimes associated with the triple negative breast cancer, and this is a very, very bad prognosis. Then we have the mucinous or the colloid, where we have mucin pools within the tumor. So when the tumor is cut off, we do a constitution of the tumor, there can be mucin pools within that tumor, and it's most common in the elderly, and it has a good prognosis. Then we have a tubular or well differentiated, and it has an excellent prognosis. Then we have a papillary or front-like, which is found in postmenopausal women. Then the inflammatory, which has a very, very bad prognosis, because for it affects by the time it presents, most of the time it is very late, and it is, whenever we have inflammatory breast cancer, we just grade it as grade stage 4 cancer. Then we have Paget's disease, which has whereby we have malignant cells coming out in the nipple epidermis, and Paget's disease is going to come as eczema. But the thing is, it may not be bilateral like eczema. So eczema is that irritation of the skin, like some kind of dermatitis around the skin, and then it's going to begin like that. Then over time, it's going to erode and break through the nipple. So Paget's disease, consider that whenever you have Paget's disease of the nipple, probably behind that we are having a ductal carcinoma in situ or an invasive ductal carcinoma. So the diagnostic approach is that when we are approaching breast cancer, we are going to do the triple assessment, and this is always the essential first step. And triple assessment is going to begin with a clinical examination, then we do imaging, and then we try to do the histopathology or the pathological confirmation. So in the clinical examinations, we want to inspect and palpate the breast and regional lymph nodes, and we want to palpate for axillary, supraclavicular, internal mammary lymph nodes. We note the changes, the location, the mobility, and the skin changes or nipple changes. Then on the imaging, we want to do a mammography, that is first line for women over 40. And we don't do a mammography in women less than 40 years because this is radiation. And most of the time, you're exposing this person to radiation. And when you expose them to radiation in a highly proliferative tissue, this can increase the risk of malignant transformation in this, which was otherwise normal tissue. But then also these people have dense breasts. And when you look at the picture of cancer on mammography, cancer appears as dense. So if you do a mammography in someone with dense breasts, it would be very difficult to actually tell the density. Is it from the breasts themselves or from the cancer? Then we have ultrasound, which we do for younger women or people with dense breasts. And for it, when we do ultrasound, we can tell about a solid from a cystic lesion, where the cystic lesions contain fluid, solid lesions contain, and normally in cancer we have solid lesions. Then we can do MRI for high-risk patients, or where the two modalities have not given us something differentiative. We do the MRI, and it can also tell us who has multifocal or multicentric disease. And multifocal and multicentric is going to be talking about the location of it. Or if we have an inconclusive, then we're going to report this. Our imaging findings are always going to be reporting using the BI-RADS reporting system, and the moment I will explain the BI-RADS reporting system briefly. Then after we want to do a pathology of intervention, that is the fine needle aspiration cytology, which is quick and minimally invasive and good for cytology, but it also has its limitation when it comes to breast cancer. And the core needle biopsy is always going to be the preferred method of biopsying breast cancer. So you're going to go with at least a bigger needle. You remove some tissues from the tumor, and then you are going to use also those tumors for receptor testing. Remember, we have the possession and estrogen receptors, so you will need that. Then we have an excisional biopsy, which is rare. And we do it with a core needle biopsy, which is our preferred method, is inconclusive. Then additional investigations, we can do receptor status testing, that is for the estrogen receptor, progesterone receptor, the HER2 receptor, and then they also help because they guide actually the therapy. Then we can do workup for metastasis, where we do chest X-ray for lung metastasis, LFTs for liver involvement, bone scan for bone metastasis, and PET-CT for advanced or metastatic disease. So when we talk about the BI-RADS system, the BI-RADS is going to come from 0 up to 6. And when we have an imaging done, we're going to report as follows: 0 if it's incomplete, and what we do is that we shall do repeat imaging. If it is a 1, then if we are negative, there is nothing found on imaging, and we are sure, we give it a 1, and that is a negative. Then 2 is when we have a benign finding, maybe a cyst, well-defined borders, good, it is small, then we give it a 1. That is for when we are sure it's benign. Then if it's probably benign and less than 2%, then we are going to give it a 3, and that will require sentinels follow-up. If it's suspicious, we give it a 4, and then we'll mostly want to go with a biopsy after that. If it's malignant and we are sure it's malignant, we are going to do a biopsy and also treat. Then in 6, that is if we already have confirmed cancer, and we shall report that as according to the BI-RADS as a 6. So we're going to look at the staging of breast cancer, and it's going to come from, so we have the TNM staging, where we consider T the tumor, N the lymph nodes, and then M for metastasis. So when we look at breast cancer tumors, we have the TX, that is when the primary tumor is not assessed. We have the T0 when there is no evidence of a primary tumor. So you have assessed, but there is no tumor. Then we have the T1. In breast cancer, we start with the TIS, whereby we have a tumor in situ, that is a ductal carcinoma in situ, a lobular carcinoma in situ, or Paget's disease without infection. That is a TIS stage. Then we have the T1, whereby the tumor is less than 2 centimeters. We have the T2, where it's greater than 2 centimeters but less than 5. We have the T3 when it's greater than 5 centimeters, and the T4 when we have any extension to the chest wall or the skin. So when we have the inflammatory carcinoma, it's always going to be T4. And then we have these small subtypes like T4A, T4B, T4C, T4D. These ones are just specifications. But the major is going to be TX, which is no tumor assessed, T0, no evidence of primary tumor, T1, less than 2 centimeters, T2, greater than 2 but less than 5, T3 greater than 5, T4 if we have any size or direct extension. Then we go to the nodes, NX when the nodes are not assessed, N0 when there are no regional node metastases, N1 when we have 1 to 3 movable axillary lymph nodes. So we have lymph nodes, but they are still movable. Then N2 where we have fixed or metered lymph nodes, and those are 4 to 9 lymph nodes. And then N3 is when we have other lymph nodes away from the axilla. We have axillary lymph nodes as well as infraclavicular or supraclavicular or internal mammary lymph nodes. Then we can say that is N3. Then for metastasis, if we have no metastasis, that's M0. If we have metastasis, then that is M1. Then after attaining these TNM characteristics of a tumor, then we can stage them. So stage 0, we have a tumor in situ and no lymph nodes, no metastasis. Stage 1, we have a tumor less than 2 centimeters, no nodes, no metastasis. In stage 2, we're going to have either no tumor or tumor size 3, that is greater than 5 centimeters but no invasion elsewhere, and no lymph nodes or N1, then no metastasis. Then stage 3 is going to give us tumor size 0 to 4, lymph node staging 2 to 3, and then no metastasis. Stage 4, if we have any metastasis, then that's stage 4 cancer. So after that, we're going to look at the complications of breast cancer. Sometimes we have local and regional spread, that is recurrence or lymphedema, and because cancer infects the lymph nodes, so when it affects the lymph nodes, we are going to have destruction of the lymphatics and then the lymphedema. Then we can have a systemic or distant, things like the metastasis, the treatment toxicities, chemotherapy is toxic, radiotherapy. Then we can have a psychosocial and the functional complications, that is anxiety, depression, body image, sexual dysfunction, fertility issues. Remember, this is a person you are going to probably consider mastectomy and everything else. And these are disfiguring things. But with time, okay, things have improved. There are things like breast reconstruction surgeries and stuff like that, but it's still not any chance. It doesn't feel any less scary. Then the management is going to be multidisciplinary, where we involve a surgical team, systemic therapy, radiotherapy, and supportive care and surgery. Early, we can do breast conservative surgery with sentinel lymph node biopsy, where we can do a modified radical mastectomy, and then when it is advanced, we have to do a palliative mastectomy and excision for ulceration. And reconstruction can be done, breast reconstruction, which can be immediate or delayed. Then we have radiotherapy, which you can do post breast conservation therapy, or if we have large tumors or we have positive margins. This is when the tumor has been cut but the margins are still showing some signs of cancer and nodal disease. And these ones will give around 45 to 50 GY of an external beam. Then systemic therapy, where we can do chemotherapy, neoadjuvant, adjunct, and palliative. So we can use hormonal therapy, that is tamoxifen and aromatase inhibitors, that is in tamoxifen in premenopausal, aromatase inhibitors, that's postmenopausal, because in aromatase inhibitors are going to prevent that aromatization of other hormones like testosterone to estrogen. Then we can do targeted therapy, that's trastuzumab, pertuzumab, and lapitinib for the people who have HER2 receptor positiveness, and then immunotherapy and suppurative and palliative care. And I think I've covered a lot of things when it comes to breast cancer, but the last concept that is important to know is about the risk, the screening of breast cancer. And here we can find out the risk with a modified GIL risk assessment tool that has been put in place, and you can always check that out and understand how it works. It's important to encourage self-breast examination in patients, who actually in all women, and this is going to be done monthly after menses, and then annually we recommend a breast examination by a qualified personnel, that is a doctor. Thank you very much. My name is Benjamin. I hope you enjoyed this video about breast cancer and also learned a lot. We'll meet next time. Have a nice day.